Good evening, everybody. Welcome to the December 17th edition of Peer-to-Peer Academy. Today, I am happy to be joined by a good friend of mine, Anu Ondhia. Anu is out of Prism Eye Institute in Canada, in Ontario. Anu, why don't you introduce yourself?
Not terrifying at all. So, my name's Anu. I've been in practice for gasp, shock, and horror about 17 years. I'm an optometrist by trade, but I like to say I don't really practice optometry in the traditional sense. And so, much like yourself, Nick, I do a lot of OD-MD collaboration, everything from cornea, refractive surgery to glaucoma anterior segment. And in the last few years, my passion project has been a lot of this, elevating our profession and kind of working together and kind of exploring this little niche that we've kind of carved out for ourselves. So thank you for having me.
Yeah, so tonight we're going to talk all about phakic IOLs. So we're going to talk about a little bit about the history of phakic IOLs, kind of where we started, the theory why we like them. We think of refractive surgery as, my patients especially think of LASIK as synonymous for the only refractive surgery that exists. And LASIK is a great procedure. This is not meant to bash LASIK. We do plenty of LASIK at our practice. I know you guys do too. But this is talking about the alternatives and why there are advantages. So let's dig on in. Financial disclosures, again, Anu and I, this is COPE approved. All relevant relationships have been mitigated for this talk. So myopia progression, this is, basic, right? Our population as optometrists especially, we know that our population is becoming more and more myopic. From 2000 to 2050, we're expecting that it's going to be affecting half of the population by 2050, sevenfold increase. 1 billion people of high myopia, so -6. Now we think of phakic IOLs are specifically for people who maybe fall out of the category of a candidacy for LASIK, the high myopes, and 1 billion people are going to be affected by high myopia. So there's been kind of an increased demand, and we know refractive surgery is cyclical. We kind of have these peaks of interest and then kind of a trough, and then a peak and a trough. 2020 for us, at least in the States, because of COVID, we found patients were really hugely demanding refractive options. And there's a lot of theories about why. I think a big part of it has to do with the masks. We were all wearing masks back then. I know Canada, you guys were wearing them for longer than us. But patients came in and they were just fed up with getting the fog on their glasses, or their contact lenses were rotating, or they were just having discomfort there. So we had this increased demand for refractive options, and that's kind of led to a little bit more of a resurgence. I think things have kind of calmed down the last couple of years as we've kind of come out of the pandemic, but we still do have an increase in demand overall as compared to about 10, 15 years ago. And again, just kind of why. COVID-19, I think a big part of it, the increase in myopia. MarketScope, in fact, predicted a 17% decline in 2020 compared to pre-pandemic numbers, but we weren't really expecting to rebound until 2022. So, history lesson. Let's go back in time. Let's go all the way back to 1974. This is when our first RK was done by Fyodorov. Hand-free razors in a blade using depth to measure the incision depth. Kind of rough when you think about it. RK is a pretty precise procedure, and we've all seen horror outcomes with RK. Some patients have decent outcomes. However, most of them have really irregular outcomes, higher order aberrations. So back in the early days, that was our first instance of refractive surgery. RK was done in the US 1978. Marguerite McDonald did the first PRK, so our first kind of more traditionally sensed laser or traditional corneal refractive surgery. And then 1990, we finally introduced the microkeratome, which is the earliest generation of LASIK. Now, in 1999, we finally got LASIK in the US. I knew you guys had LASIK well before that, though, correct?
Yeah, so I think we were probably around the 1990 mark. So I think, in some respects, we get a little luckier than you guys by quite a few years, actually. And you're going to see that pattern probably emerge in a few of the other things we're going to talk about as
You guys
well.
get all the good stuff
I
before we
know.
do.
But then we get to try it out, and then we can share our pearls with you.
That's true. You guys can be guinea pigs, I guess. That's fine. We'll take the good with the
Don't
bad.
tell our patients that.
So, we think RK as being the earliest refractive procedure that we had. At least I always thought that. But in reality, phakic IOLs were done before that. Barkhurst, Stamprelli, and Choice, these are our first three pioneers of phakic IOLs. And we knew early on that attacking the cornea and doing things at the corneal plane wasn't always the most predictable. It wasn't always the safest. At this point, though, keep in mind when our first cataract procedure done with an implant that wasn't until 1949. So we had really little experience, or these three had really little experience with any IOLs, let alone a phakic IOL. When you're inserting a lens into an eye that is phakic, there's just less room to work with. And so we ended up having problems with, the biggest one was corneal endothelial, corneal dystrophy, or corneal decompensation. We didn't even have microscopes, so we're kind of doing things on the fly. Big sutures. We didn't have viscoelastic. Viscoelastic is there particularly to keep the anterior chamber, keep its shape, but also prevent problems with the endothelium of the cornea. We didn't have that. So we were just kind of setting ourselves up for failure with these early lens designs and these early procedures. So we kind of backed away. Then again, 20 years later, we had these three: Wurst, Bykhoff, and Fyodorov. Now, Dr. Wurst, again, he's a pioneer, but that name is not great. He had issues with the same things. We were trying to decide at this point, where do we put these things? Do we put them in the anterior chamber connected to the iris, like Dr. Wurst did? Do we put them anchored into the angle, like Bykhoff? Or like Fyodorov again came back and he put the lens behind the iris, and so we had this sort of design where we had most of it sitting behind the iris, and we had the optic that actually came through the iris. So we're just trying to figure out where is the best spot, where is it going to keep the patient the safest with the best visual outcome. But again, it didn't work out as designed. There were definitely some good outcomes, but more often than not, we had a lot of problems, big time problems with the cornea. Corneal decompensation, these patients were looking at not only explants, but now they're looking at corneal transplants. And think of early generation corneal transplants. We had issues with those. So these procedures took a back burner. LASIK came around right after that, early 1990 in Canada, and for the States, late 1999. So LASIK was right on the heels of this phakic IOL push, this sort of renaissance, and again, kind of shoved it into the back burner. Until 1990, Dr. Fyodorov came along with the collar button. This is his earliest design of the ICL, and the common ICL that we'll talk a little bit about later, the implantable Collamer lens. The ICL is a ciliary sulcus based lens that sits posterior to the iris, anterior to the crystalline lens. And Fyodorov's early designs kind of mimic that. We'll talk more about that as we go. Why don't you take it from here, Anu?
Sure. So, I think it's interesting. So there's different lenses, different landscapes, although our two countries, I think the demographics are probably not all that far off. We do have different names for certain things. So the Verisize, which is what you guys have in the US, outside the US, is called the Artisan lens. And so it's an iris enclavated lens. And so it's got these little kind of pincer claws that go, clip onto the iris. And we still use it. So, if you think about the difference between these kind of refractive patients, you look at those slides that Nick showed with, some really funky looking IOLs. And obviously our hindsight is, kind of, it's a little cruel to look at it from that lens. But, you look at those things and you think, man, these are patients who otherwise had pretty healthy eyes and they were just looking at refractive outcomes. So to kind of cause those big issues and end up with, nothing like a DMEC, a DSEC, a DALK, nothing like that. These are full thickness corneal grafts that people were ending up with, early cataracts, things like that. Really big problems, sight-threatening complications. Then you had these lenses like the Verisize, like the Artisan, that have been, in use for quite some time. So, for a while we were using these in our refractive cases, sometimes the Artisan, Artiflex, they were sort of known as, and they're in the anterior chamber. And so just by nature, they had some issues, because of their location biologically to the corneal endothelium particularly, but also to the iris. It's pretty invasive. It can cause issues sort of over time that we'll kind of look at there. But they are still in use. So in our practice, for example, we deal with a lot of complex anterior segments. So patients for secondary IOLs, patients with no usable bag. And so, AC IOLs are not completely, off the map, but they certainly have kind of fallen out of favor when it comes to these kind of really healthy, usually young patients that are seeking refractive outcomes. The ICL, or the implantable Collamer lens, not the implantable contact lens, which I feel like is one of those things that just never dies. I feel like I hear this. I actually heard it today, and I was just like, I had tried, resist the urge to roll my eyes. So Collamer is actually the material. So we're going to talk about that a little bit. So it's a very specialized material. It is proprietary, 2-star surgical. And so this lens, actually, we think about it being like new, novel technology. Of course, the marketing programs we've seen in the last couple of years, with some famous singers and athletes and things, we think this is brand new. But actually, looking back, the original, legacy ICL was back in 2005. So it's been around for quite a while. And you think about, LASIK for 1999 for the States, really not that far off. But this was moving kind of posteriorly, so looking into the ciliary sulcus with a pretty wide range of powers there, both for myopia, but also for astigmatism. And so this is kind of just a little bit of a spotlight on the Verisize or the Artisan lens. So again, did get FDA approval quite a while ago. You need a pretty deep ACD because, of course, that's where you're placing the lens. It's PMMA, and I think that's really the biggest difference between this lens versus an ICL, for example. So the Collamer material is a very soft, pliable material, and that's excellent for the surgeon who can kind of roll the lens and inject it through into the eye quite easily through a very tiny incision, whereas you have PMMA insertion, it's hard, it's rigid, it's brittle, and to put that into the eye, you need a nice big incision, big sutures, surgically induced astigmatism, longer healing times, propensity towards more infection risk, and just longer healing times. Not a nice experience for the patient. The optic diameters there is actually quite similar, and then it is 8.5 millimeters in length, but yeah, in the anterior chamber. And I think the key is really that rigid material.
Yeah, that's a good point. I think we always forget about that because we don't see that a lot in the States. We see much more ICLs than we see the Verisize or the Artisan, but it is hard. And so to get a hard lens, you can't roll it up like a taco like you would a traditional cataract. It has to go in pretty much flat. And you can get up 2.5 diopters of astigmatism correction, which is great, but how much are you going to induce during the procedure?
There you
and
go.
is
And
that
then,
lens going to actually anchor where you want it to be?
yeah, I almost wish I'd put one of our post-op cases in here with like the really large like cross suture. So this is not like a single temporal suture. These are like big X-shaped, causing all kinds of sills. So even though you calculate for what you're doing post-operatively, you then have to re-evaluate what's going to happen when you remove the suture, what's going to happen to that cylinder power. So you're absolutely correct. It's definitely a bit of a minefield there. So yeah, that's what those look like there. Different models with different optic sizes. And so these are kind of some of the studies. So it's not really a small study here, and really just highlighting the issues. I think we can kind of surmise what would happen when you put these lenses in there. Many of you may have seen these sorts of things in there. Patients had decent vision, 20/40 or better. But when we think about modern day, LASIK, ICL, 2040 seems, like a bit of a miss. We're past 2020 now, we're targeting down to 2015. And of course, with things like, topography guided treatments and things like that, like I think our expectations are certainly much higher than they maybe were back then. And looking at how many patients still gained vision. So, I mean, still an excellent option. 54% of patients gained, a line of vision, but some also, lost some vision. So some pros and some cons there. And looking at the endothelial cell loss. So of course, being in the anterior chamber, the risk to the endothelium is not insignificant. We of course lose some amount of endocell density just with age, and of course with any kind of intraocular surgery. But this is certainly higher than the averages, for age norms.
Yeah, I always like to look at the 71 to 76%. It is pretty not great. I mean, think about LASIK. LASIK, within a half diopter, that's our landing zone. We're closer to 90% with LASIK. Cataract surgery, traditional cataract surgery is more like 70%.
That's right.
And ICL, we'll get into that data later, but it's definitely higher.
Which is interesting because they come in in half diopter powers, just the same as kind of cataract lenses. So that's really interesting that kind of that differentiation exists there. And I wonder, what that's sort of down to. So that's interesting. So yeah, certainly some pros and some cons. So when we talk about any kind of phakic IOL, one of the big pluses, one of the big, I hate saying selling points, but selling points is that it's reversible. So it's an additive technology that can then be removed. I wouldn't say it's necessarily totally reversible, but can certainly be removed if needed. I can say, with modern day ICLs, we haven't really had to do that. With the original legacy ICL, we have removed a few just when patients naturally age into, cataract age. That's certainly an option. You can get these great ranges of correction, nice large optic zones. So you're not going to have dysphotopsias and issues like that nice stable toricity. For the most part, we've seen these dislocate. So when these types of lenses dislocate, we actually call it a de-enclavation. And so you can actually go back and reclip it onto the iris, but of course there's trauma there. Iris, translumination defects causing photophobia, and glare for the patient. Obviously not a nice outcome when you're searching for refractive freedom and you end up with this issue. We've talked about endothelial cell loss. And I guess, invasiveness is kind of an interesting term that we'll sort of come back to a few times, this evening. And I think it kind of depends how you're looking at it, but I think most of us would agree that, taking a chunk out of the iris probably would qualify as pretty invasive. And it does have its complication rate that we sort of looked at there. So certainly has its place, I think. Certainly in our practice, this is something that we do on a fairly regular basis. But again, these are for patients with kind of complex anterior segment needs as opposed to our refractive patients.
All right, so let's talk a little bit more about the ICL then. I mean, so we talked about what is negative, and again, these aren't. I don't want to bash any procedure, but fast forward to 2024, and we just have options that are a little bit more accurate, a little bit more safe, and are for a more wide range of patients. So looking at the ICL, I mean, the range of refractive correction is about as much as the Artisan or the Verisize. I mean, -3 to -18. So you're really capturing a wide range in the States. Now, I knew you guys get the good stuff in Canada. What's your range?
Yeah, so we're really lucky. In Canada, we can actually apply for special permission to go down to half a diopter in terms of a spherical power and all the way up to 20 diopters. And we have up to 6 diopters of cylindrical power. And not to really bother you on this term, but we also get hyperopia and hyperopia toric. So we're really fortunate that way that even before things come through approval, we get access to these powers. Now, don't forget that -18 is not at the spectacle plane. So there's also kind of that factor.
Right. Yeah,
There, right?
exactly. So, -18, that does go. Vertex is backwards compared to a contact lens. So -18 would be like a -17 or so at the
Absolutely.
spectacle plane. The
Yeah, and you can
key,
certainly, debulk a pretty good chunk there, even if you do have patients that don't quite, have everything corrected there.
yeah, and we've had patients who were highly myopic. So I think the highest that we've ever done was like -24 or so, huge eyeball. And he wanted ICL. Obviously, he came in. That was the only option. You're not going to do LASIK on somebody like that naturally. And I counseled him. I'm like, hey, man, like we can do this. It will definitely be, I think, considerably life changing for you. You're going to go from -24 to a -6-ish until you can go back to wearing soft contacts. You can see your bedroom door in the middle of the night. It's still very blurry. Don't get me wrong. You're -6 still, but it's better than a -24. And we cautioned him very, very carefully. We want to make sure you understand what you're getting into. He was the happiest patient. I mean, we left him a -6 because that was the biggest lens we could possibly get. Now, I know you guys go to -18, right? It doesn't go past
Yeah.
that in Canada.
Yeah, yeah.
Okay. So in the States, -3 is as low as we can go. And I think the common belief is that ICL is reserved for people who are only highly myopic. And I fall into that category 5 years ago. I didn't know much about ICL before I joined with my current partner, Dr. John Vukic. I thought ICL was your -10s, your -12s, and anything lower than that, that's LASIK all day or PRK. And my Venn diagram that I've got in my head, I've got LASIK, I've got ICL, and there wasn't a whole lot of overlap. Well, fast forward to now, after the experience I've had working with these lenses, there's much more overlap. So a -3, that for most people is very easy LASIK. And, honestly, -3, I talk to them about ICL. I give them the pros and the cons, and I tell them that, hey, LASIK is a great option. ICL will get you probably exactly, if not better, vision, and also will come without the negatives, some dry eye, some glare, and it is removable. If you don't like it, now we've never had to remove it, not the Evo ICL. But if you didn't like it, that's comforting for patients. And so, that I think is really appealing for those certain individuals. The ICL comes in 4 different diameters too. So we're looking at 12.1, 12.6, 13.2, 13.7, and that will directly affect the vault. And we'll talk about vault in a little bit, but basically, how much room do you have to work with between the iris or the anterior chamber and the posterior cornea and the anterior crystalline lens, you've only got a certain amount of space to work with. So that anterior chamber depth of 3 millimeters is incredibly important. We need to have enough space. We're not taking anything out. With a cataract, you're taking a lens out. You're creating a lot of room. That angle is going to shallow, or it's going to deepen up. You're no longer worried about narrow angles anymore post cataract surgery. Typically, with this, that is a big thing that you have to look at. So when you're evaluating patients, you got to look at that.
Do you find that you ever get patients that are typically disqualified because of ACD? Like with our myopes, I find that pretty rare.
It depends on where they're at. So yeah, I mean, we do. There's definitely some patients that do. If they're highly myopic, rarely. I mean, usually they're going to have pretty deep anterior chambers. It's the -3, the -4, the -5. That's where that we kind of have to use that into determining which procedure we're going to go with. That's going to be the one thing that's going to rule them out. So I know you guys have a minimum of 2.8, correct,
We
on label?
do, yeah. So outside of the US, and these are for on-label uses, of course, there's surgeon discretion and kind of different
Mhm.
factors, that people will kind of use for that. But yeah, so for us, it is approved for 2.8 millimeters.
Yeah.
And again, internal. So I like that you mentioned that. So we're not taking into account the thickness of the cornea. So it's not to the epithelium, it's the internal, so just to the endothelium.
Yeah. So you got to have enough space. And of course, off label, there are
Yeah.
surgeon discretion based on medical judgment. But 3 is a pretty comfortable amount of space set by the FDA. A little bit about the history here. Just 2005, like we said, we had our first lens. We had the toric lens introduced in 2018. So we had 13 years where we were only doing spherical equivalent. And that's the legacy ICL. That's the ICL that required a PI. And we'll talk about that here in just a little bit. But 2022, things changed dramatically. So we had the EVO ICL, which I knew you guys had that a lot longer than we did again. And it was available in Europe a lot longer. But the EVO ICL has dramatically improved our safety profile. The visual outcomes were impeccable with the legacy ICL. But now since EVO, any complications that we did see, and we saw them, we saw issues with the legacy. I mean, I'll get into a case here in just a little bit. You don't see that anymore, not with the EVO.
Well, I like that the Evo is so easily recognizable too. We were actually chatting about this the other day that if you didn't know somebody had a legacy ICL, it's actually really hard to see within the eye. It's in the posterior chamber and it's just, you might see a little glint at the slit lamp, but it's tricky. Like unless you know what you're looking for, whereas the Evo, boom, immediately you see that kind of central aquaport. Now, there actually are 5, and I was teaching our fellow about this, and they're going, oh yeah, that's the one with the one hole. And you're going, well, actually, there's 5 of them. So there's the one that you see in the center, which is kind of the claim to fame, and we'll kind of talk about why that's so important. That's a huge design feature. It's such a small thing that kind of really made the world a difference, as Nick mentioned. It gets rid of the need for a PI, which is awesome. Second stage procedure, all the risks that come with that. We think of it being a fairly benign procedure, but it got rid of a big deal there. But it also there's two other full thickness holes on the perihaptics and then on the foot plates as well. So there's a lot of kind of aqueous flow going. And if you're looking at the positioning within the eye, it allows the lens to vault over the natural crystalline lens. And because the aqueous is constantly flowing all the way around it, it's bathing the crystalline lens and really having this protective effect. So it's a small thing, but sometimes the small things are the big things.
Yeah, definitely. Especially when you're working in a world of microns, small
Yeah,
things make a big
absolutely.
difference. I
Yeah,
want
it's
to
all
take a
these
moment real
incremental
quick
differences.
to remind everybody too.
Yeah.
There's a button that says submit questions. So we want this to be interactive. If you have questions, please submit them, or if you have topics, comments, please submit them. The toric. So the toric was kind of the 2018. That's what we had 13 years in the States of not having any toricity. The unique thing about the ICL is that the toric lenses are designed, those have to be manufactured custom. And so in order to keep the inventory down, they come at certain degrees. And so when you order a lens, you can order based on what toricities are available. The lens is designed to go in temporally, and then you can rotate it up to 22.5 degrees to meet the toric axis, the refractive toric axis, not the corneal toric axis, but the refractive toric axis, where it's indicated where our calculations are measured. So evaluating these post-op, you can't rely on your topography to determine where the lens is supposed to be, like you could with a toric IOL. If I know that I got a patient who's got with the rule cylinder at 90 degrees, that toric marker should be at 90 degrees. This is not like that because the toric power is designed in the lens, and the lens is supposed to be going in. It could be rotated anyway. So you have to really know what the attempted versus the achieved was. And this is what the order form kind of looks like. So our surgeons go into this in the operating room with them. It tells them exactly where the lens is supposed to be. We've got all of our data up here: the lens design, the size, the target and everything. This is what they go in. So it tells them to rotate the lens clockwise by 5 degrees. And I look at this at day 1 or day 0 too. We see them day 0 for a pressure check. They're usually very dilated at that visit. A few hours after the procedure, you can see exactly where that lens is supposed to be. And that really helps kind of determine, did we hit our mark? So they do come with risks, though. The big one, obviously, we are putting something in a very small space. Pupillary block is a very real thing with the legacy ICL. We did need to do a PI. A PI was necessary to allow a passageway from the anterior or the posterior chamber to the anterior chamber to further reduce the risk of pupillary block. We also have the issue of cataract formation. We saw premature anterior cortical cataracts or anterior subcapsular cataracts with the legacy ICL that happened at a relatively young age. And so that was something that we really did deal with. 5% of patients developed an early cataract. And a lot of them had to be explanted. Now, pupillary block was not common. It was usually remedied by a second PI. It did happen. And again, think about the procedure. You're taking a healthy eyeball, a person who is functioning well for the most part. They're functioning okay. It's an eyeball that is healthy by all accounts. And we're putting them, it's an elective procedure. So you're taking this really big thing. They paid money for it. And now we're giving them pupillary block. Well, that's not always an easy pill to swallow. Now, for us, Anu, I know you've got experience with this too. The PI was probably the worst part for a lot of people, right? What do you think? What's your experience?
I mean, I work in a glaucoma clinic, so of course PIs are not like a foreign concept. They're not something that we shy away from by any means, but certainly very much like you alluded to, it's the refractive patient versus the medical patient. It's a very different world. Just the whole risk benefit, the goal, the expectations that are kind of set there, and whether they're met or not, I think is really important. So, PIs, they mean it 2 steps. So, for patients, we live in a huge metropolitan area. We'd have patients coming in, all that way for a secondary, just from a convenience standpoint, that's not ideal, but you can kind of get over that. You can have pain, you can have bleeding. Those patients with those kind of the ciliary body right up there, and they're really just like, they're really put off by this procedure. And, you get the odd patient, we tend to see it a lot less these days, but you can get patients with pressure spikes, a little bit of inflammation. And, to me, the worst thing would actually be some form of dysphotopsia or glare. So you used to see patients with these kind of streaks of light, in their line of vision. And so you think this patient is, perhaps correcting to 2015 or so with their glasses, with their contacts, they're otherwise a nice, healthy eye. They come in for this procedure and they get this kind of like intractable, dysphotopsia. Now what? Are they probably going to go ahead with the ICL? Probably not. So they're going to be angry. They've now got this issue. Then what do you do with it? You got to think about like corneal tattooing, maybe. Maybe they won't. Maybe they'll just, have this trauma from eye doctors for life. Who knows? Maybe a little extreme, but it's, it's just been really, really nice not to have to deal with this. How about yourselves? Have you noticed a big kind of difference there?
Yeah, I mean, because also the PI that you're making, it's not a tiny PI. It's got to be big enough because it's not like a questionable narrow
The
angle.
usual.
This is an angle that is going to become narrow because you're going to make it narrow because you're putting a lens behind the iris. So you have to have a good PI. Our patients did not like that. I mean, it's not the medical patient, it's the refractive patient. Their pain tolerance generally is a little bit lower. So we had to pilo them, and then they're kind of achy after. And I think if you asked, 10 of our legacy ICL patients, was the procedure itself the worst part, or was it the PI? At least 9 of them would say the PI. I'm positive. But cataracts too. I mean, PI is not a benign procedure by itself either, right? Like you said, I mean, it's something that you are creating an issue. We also have the chance of igniting a cataract because you're changing the entire aqueous flow. And the aqueous flow and the normal pathophysiology of aqueous through the eye, that's a big part of what drives cataract formation, at least premature cataract formation. So changing that, you have the chance of changing the lens physiology, leading to a cataract. So it does have a significant consequence in certain patients. But we had to do it. That was a part of it. And that's kind of what brings us to this case. So spoilers, this does not go well. So this was a 39-year-old we did. This was right before the EVO came out. EVO came out in 2022, April 2022. This is 5 months before that. So it would have been nice if we had that knowledge. We didn't know when it was coming out. We just knew it was coming. It would have been nice. So anyways, patient, she's -9. She's a perfect candidate for ICL. Her anterior chamber depths are very deep. She's 3.34 in the right eye. She's 3.36 in the left. I put her pachymetry on there, although it's irrelevant. We're not doing corneal refractive procedure. So the packs don't really matter. She does have a diopter of astigmatism on her corneas as well, but she's a spherical correction. So we did a spherical ICL.
So when you say it's a spherical correction, have you done any topography, or what kind of would make you decide that?
No. So for this, I mean, think of a cataract calculation. You really are relying on your topography to guide your toricity because you're taking a lens out. This is kind of like fitting a contact lens. You don't fit a contact lens, at least you don't fit a contact lens. And I'm not a contact lens guy at all. I haven't fit a contact in years. But I don't think you fit a contact lens based on the corneal sill. Now, you may fit the type of lens based on the corneal sill, but the refractive power is all driven by the refraction. So for ICL, it's all based on our refraction, which is why I think optometry has a really powerful role here, because you got to have a good refraction. Garbage in, garbage out.
Yeah,
Right?
we definitely try to do like our wet refractions, and sometimes we'll do an over refraction for those super high, like traditional ICL patients, I guess you want to call them. How about you guys?
Yeah, we do over refractions too. So a lot of times I will throw, not all the time. I will throw a high power lens on for somebody who's like a -10 or 11 or 12. You have a wider landing zone for those patients. You all know, if you're refracting a patient who's a -12, you can go several clicks with a phoropter and they're going to say, it's better, that's better, that's better. They're going to give you wishy-washy answers. So if you can reduce the minification caused by the high lenses, the high lens powers, do that with a contact lens and then do an over refraction, you'll get better answers. And so we do that case by case. It's not a standard thing that I do, but it's definitely something that I have, it's a trick in my sleeve that I have if I need it. So back to this case, the procedure went beautifully. She had a PI done, and then we had our surgery done. We always did it about 2 weeks after. We always wanted to make sure that the PI was patent. We did a pressure check the day of, and that's pretty critical with this. You want to make sure that, because there's a lot of viscoelastic that you're using for this procedure, the pressure tends to be kind of high, but most importantly, with the previous version, you want to make sure that the PI is patent and the pressure is not skyrocket. This patient was great. Pressure was, pretty normal. That's kind of what we would expect for day of. Came back the next day, her pressure was better, perfect. I did note on her exam that her angles were narrow. I was a little bit worried that maybe we had picked a lens that was too big of a circumference, too big of a diameter. If you've got a big diameter, it's going to vault higher over the crystalline lens. Your angles are going to narrow. So I noted that right then at day one, like, ooh, this is a little high, but her pressure was fine. I thought they were open. Everything looked okay. We're going to watch her closely. And I planned on seeing her back in a week. Typically, the ICL settles down. So if it's a high vault, it'll kind of flatten out a little bit. We would expect the angles to, at least that's what I was hoping, that the angles were going to open up and we wouldn't have to take her back to the OR to replace the lens with a smaller diameter. I was wrong. Unfortunately, she called Friday morning. She had called. I remember this like it was yesterday. I was I work out in the morning and I was on the treadmill, I think, and she called at like 6 a.m. and I was like out of breath, and I knew who it was. She's like, "Hi, this is Mia." Oh shoot, I know exactly who this is. Oh no, okay, and I could tell right away she was in pain. I knew exactly what was going on. I didn't even need her to tell me. I said, "Okay, just let me shower quick. I gotta I'm like drenched in sweat. I'll meet you at the clinic right away." So I saw her in the clinic right away. Pressure was 70. Of course, you got a healthy patient who is now miserably in pain. She's vomiting, and it's just not a fun day. I look at the slit lamp. I don't even need to look at the slit lamp, but I did. She's got significant corneal edema. You can't really see anything. The iris is completely bunched up to the cornea. Can't really visualize anything else. We ended up having to do a PI that day, and then we got that down back to 15 millimeters of mercury. So the PI took care of everything. That's how you know it's pupillary block. The PI will definitely help. Now, if a PI didn't help, you can have pupillary block, or you can have angle closure without pupillary block. That would have required us to do an emergent surgery, taking the lens out, and that would have been worse. But thankfully, it was angle closure with pupillary block. The PI resolved the issue. I put her on the kitchen sink of drops just to be sure, and she came back Monday. Monday, we got some pictures. She was actually, comfortable, so we were able to take pictures. Her angles were much better. They're not too narrow. You can see the anterior segment OCT. They're a little bit on the narrow side, but they're not bad. Her PI, we did a second PI in her right eye. Her left eye was doing fine. We ended up doing a second PI there just as a precaution as well. Her ICL vault was about 500, which is kind of where you want it to be. You want the vault to be anywhere from really 250 to 750 or 800 or so. 500 is smack dab where you want it to be with the legacy ICL. The EVO, we have a little more flexibility. But we told her to continue her drops, and we started 2 weeks later. So the theory is that there was pigment that was released during the procedure. That's why her pressure was fine the day of, fine the day after, and then it became incredibly elevated 2 days later. There's pigment released during the procedure. We're releasing a lot of pigment when we're kind of stuffing something in there. There's pigment on the posterior iris, and that can clog the PI. That's exactly what happened here. The PI looked like it was patent, but it clearly was not after that. So fast forward 3 months later, she's 2020. Beautiful case. I see her every year now, and we kind of laugh about it. She's embarrassed, and I always tell her, don't be embarrassed. That hurts. I understand. It hurts. But it was something that she wished she could forget. However, she's happy that her vision is what it is. She's very thrilled. So that brings us to the new version, the EVO ICL, which was introduced in 2022. So Anu, like you mentioned, it's got these little holes right there. One in the middle is the big one, not the big one. They're all the same size, but that's the main one. And then you've got the two kind of paracentral holes, and then one on the leading foot plate, and then one on the posterior foot plate. And that allows passive aqueous to go between the front and the back of the eye, as well as passive OVD viscoelastic removal. There's no direct irrigation or aspiration system like there is with a cataract. So that kind of allows that intraoperatively.
So you mentioned that, surgeon removing the viscoelastic. So like, with these ports, it does kind of passively kind of come out, but you do also, you do want your surgeon to remove, the bulk of that, because if they don't, you're going to have a patient like that one, despite having these full thickness ports on there as well.
Yeah, it's. I will say patients do have higher, and I guess every surgeon's a little bit different. Mine tends to leave a little more viscoelastic in during surgery, so I do find myself burping at the slit lamp, which I'm comfortable doing.
Fine. Yeah.
Not everybody is, but it's fine. They come in, they're not really uncomfortable usually. Usually their pressure's a little high, maybe a little bit of an ache in one eye if it is. If there is a little viscoelastic, we just relieve it at the slit lamp, and they're happy. But they come in day of, about 4 hours later, because that's typically when you're going to get that pressure spike, and so you want to catch that. I always get the question, well, what can I come in, an hour after surgery? Well, we're not going to catch what we're looking for at that point. You're not going to have that pressure spike, so we kind of want to wait that 4 to 6 hours to see if the pressure raises up. If it does, then we can do something about it. I don't want you to call me again in the middle of the night, because I don't like coming in after hours. I
tell my patients that. I'm like, this is when they're really pushing back, and I'm like, this is just self-preservation. I'm not worried about you. I just don't, I don't want to lose sleep.
Exactly. Exactly. Well, that little hole, I mean, that exists obviously for a reason. So here you can kind of see a schematic, the legacy ICL on top, and then the EVO on the bottom. We are seeing flow of aqueous. And that almost acts like a hovercraft or like an air hockey table is what I've heard it described. Yeah. So you've got this sort of cushion of aqueous underneath the ICL that keeps, well, number one, it keeps the lens off the lens, the ICL off the lens, but it keeps that normal aqueous flow. And we think that is probably more of an impact on premature cataract formation than we ever did. We thought it was, at least I thought it was mostly contact, physical contact. But really, it's probably more to do with the aqueous flow. And you can kind of see that here. Anu, what do you tell patients about the hole? Are they going to see it?
So I find, I go back and forth on this. Do you mention it to the patient? Do you not? The whole thing of, if you don't discuss an expectation, it's a complication. And actually, I don't mention it to patients. I'll sometimes show them the lens, what it looks like. Actually, funny enough, I've been kind of fiddling with a pen here. It's the EVO pen, and it actually has the little prototype lens in there, which is awesome. And it does have it in there. So I do show that to patients. I don't make a big deal of it. These patients are super happy with their vision. I mean, if you kind of ask them for it, much in the same way if you ask a multifocal IOL patient, do you see glare and halos, they'll tell you about it. And then you got to ask, are they bothered by it? So I think anecdotally, I'd probably say my patients, if I ask them about it, maybe for the first week or so, they'll sort of mention it, be like, there's a circle around light, but whatever, I'm seeing 20/15, I'm super happy. I'm not in pain, I'm back at work, I'm back to my life. And then after that, it just kind of disappears. So I don't know, has that been kind of your experience as well?
Yeah. Usually I kind of hint to them that there might be some glare at nighttime.
Yeah.
It's a lot like the first time you put contact lenses on. That's usually the analogy I use. It's, your first time you put them on, it kind of felt weird. And, maybe if you blinked, it kind of caught some light, especially in low light, but you got used to it. And that was the norm. And so it's usually there if they look for it. If they really are hypercritical and they fixate on it, you're going to notice it. Most of the time only in low light, and typically after a month or two it just goes away. I mean, we've had optometry buddies, I've had a couple buddies who've had this done, and they said, yeah, I don't see it anymore. And those are the people who obviously understand what's happening. Even they don't see it.
And I think
So
logically, when you look at it, you think it's going to happen, right? Like, we're all kind of trained to look for this. We're probably terrible patients for that reason, but yeah, I mean.
But I tell my patients too, especially if they're complaining about it in the first couple of days, well, number one, let's be patient. It's going to get better. Number two, if you want to go the nuclear route, we can take this lens out. It's fine. And they're always like, oh, I don't want that.
No, it's not that bad. All of a sudden, it goes from I can't live like this to, oh, no, it's totally fine.
Yeah, well, yeah. So we just leave it. Let's get into some of the data. And so I think this is really impressive here. So, I mean, this is the attempted versus the achieved for the EVO plus ICL study. So, I mean, with LASIK, if you were to go up the dioptric curve, kind of go up the scale, you would expect a wider landing zone, probably, right? I mean, typically that's what I would expect.
Yeah,
now, we are pretty much on accuracy, as accurate as we are correcting the -15s as we are correcting the -3s, which is very impressive to me. We're about 90% again within a half diopter. That's compared to the Verisize, which was 70%. Standard cataract surgery is about 70-ish%. LASIK is around 90. So we're still kind of right along where that standard benchmark of LASIK is, but we're as accurate with the high diopters as we are with the low diopters, which I think is great. And it's not dose dependent. Like LASIK is, the higher corrections, you need to take away more cornea. And once you take that cornea away, it's like putting toothpaste back in the tube. You can't do it. You can't put it back. So you're taking this subtractive procedure. Now with this, it's not taking anything away from the cornea. You're not really inducing, there's maybe some aberrations from the lens, but that's minimal. You're not permanently inducing higher order aberrations like you do with LASIK, especially high corrective LASIK, because the spherical aberration especially is significant. Now, stability. This is only a 6-month study, but I can say that, our patients that we've been doing these on for, early 2022, we were 2.5 years ago. I knew you have longer experience than I do.
2016.
Have you seen regression? Do you see regression like you do with
these
LASIK?
do really well. And I actually, typically you'd expect this, right? Especially when we talk about those traditional ICL, super high myopes or, pathologic myopes, you'd expect continued progression. And for whatever reason, they're actually reasonably stable. And, if they do come back a number of years later and they do need something, it's great. You've left the cornea alone, and it's a very different story lasering, ablating, 1.5 to 2 diopters of tissue versus, 12 to 14 diopters. Even if you had the tissue to do it, would you really want to? Your risk of ectasia and your risk of regression on the cornea, I think, is far higher, than what we see with our implants.
Yeah, the stability with the EVO is consistent with the stability of the legacy ICL. So I can say from experience that I've had several patients, dozens of patients who've had ICL done back in the early 2000s, 2005, and they came now for cataract surgery. And so these patients come with, I wasn't a part of that case, back in 2005, I wasn't practicing then. I didn't know anything about ICL back then, but they come with very little refractive error, if any, and they're now just cataract. And so the cool thing about it is that we can take the ICL out just like we can a normal lens, and they have the entire gamut of premium IOLs on the table. Nothing is limited. Like with a high corrective LASIK, you may not want to do a multifocal lens. You may not want to do a depth of focus lens. There is limited things that are more, in line with those patients. But with ICL, you have the whole spectrum. There's really
I find that's a really great point to tell patients because, of course, a 20-year-old person who doesn't want to wear glasses is not going to suddenly turn 60 and be like, yeah, I'm totally fine with full-time glasses wearer. And, we don't know what the technological landscape is going to look like in 10 years, let alone 30, 40, 50 years. So, I tell my patients, we're not treating you just for today, we're treating you for your lifetime. And so leaving those options on the table is great. I have been in practice quite some time. And so I have seen some of these removed, like the legacy ICLs or things from around the world. And honestly, it's shocking. You see them come out. There's some videos on YouTube. I believe it's Dr. Ellie's has one. And it's just like, it's staggering. These things come out and they're crystal clear.
Mhm.
I've seen IOLs, like PC IOLs removed, and they don't look like that.
Yeah.
It's phenomenal. It's done as a one step. So it's not like you take this out, you go back, you redo your biometry. No, you're in the OR one time. You remove the ICL, your biometry is all done. The lens is so thin and flexible that it doesn't impact your biometry. So there's a lot to love about it. You do your phaco, you put in your IOL, and off you go. So it's really phenomenal to be able to offer that, to these
Yeah.
patients.
Yeah, and this is just uncorrected visual
Yeah.
acuity. I mean, we're hitting 2020 very, very regularly with this. I
Yeah.
think, this is the one of the money slides. I guess this is a lot of these are money slides here, but this is the one that talks about accuracy again. And these are not small studies. The FDA study was 629 eyes. The published literature that you can compare to is 1,900 eyes and longer study too. So these are stable. They are accurate. So predicted or the attempted versus the achieved, it stands the test of time, which is great.
And so efficacy there over one is what you want, right? That essentially
Yeah.
means you're gaining vision. And those are two different studies,
Mhm.
different timelines, different modalities, different demographics, and they're really reflective of one another, which I think is really impressive.
Yeah,
When you
yeah,
read research, sometimes you're like, I don't know about this one, or you got to be a little skeptical, but that's impressive.
yeah. This is the money slide. I like
Yeah.
this one because this 52% of patients actually gain vision. So how do you gain vision? We'll talk a little bit more about this in a couple slides here, but it has to do with one little thing, two-word phrase, the nodal point. The nodal point is the center of the optical system of the human eye. Where is the nodal point? Well, it sits right at the anterior crystalline lens, right at that plane. So we'll get into it in just a little bit. We'll talk a little bit more about that. IOP stable, really no long-term change. You might see a little bit of a spike on day 0 or day 1, but that levels out. That's transient. And then here we have our study of our safety study. So cataract, with the legacy ICL was about 5%. Pupillary block, that was definitely a non-zero number. Well, in the FDA study, 629 eyes, no cataracts, no pupillary block. In the published literature of now 4,000 eyes, no cataract, up to 5 years. And then one of pupillary block which was just retained viscoelastic. So it was something that was explainable. No pigment dispersion. So these are just a dramatic improvement in safety compared to the legacy. If you work with the legacy ICL, you have the experience that we've got. You've seen these patients. I have not seen patients who have problems. We just don't get it, and that's just a wonderful thing.
We almost wonder about those, like the domino effect, right? Like you had a product that, like the legacy ICL did very well. It was very effective. But sometimes, you can wonder if you fix the safety issues, what if you then have a knock-on effect? What if it's less effective? What if it creates another issue? And you can see here that, both need to kind of go hand in hand. You can't have something that works, but is like causing all kinds of problems. And obviously,
Yeah.
vice versa. So that's a great demonstration there. A huge number of eyes.
Yeah, adverse effects really small. I mean,
Yeah.
residual astigmatism 1 out of 629, angle narrowing 2. I don't really know what they call angle narrowing. I think the angle naturally does get narrow, so I think that happens pretty much in everybody. But does it get narrow to the point where it's
Lens-wise.
concerning and requires an explant? That doesn't really happen. Flare and halos, again, we see that early on, but that's transient. That goes away. Nobody complains of that long term. So now why don't you take us through some of the pre-op consideration? How do we work these patients up when we're
Yeah,
talking
so we
about it?
looked at kind of some of the data, but I mean, as optometrists, we're often involved, as the first and last touch point when we're in the clinic, but also out in community. Patient selection is really important. We've talked to you about what this lens is, and we want to know kind of who does well with it. How do you select it? And I think, as Nick mentioned, I think we started with one very specific demographic, and as time's gone on and we've seen these outcomes, I think that's really, really opened up, which is key. We're going to talk about the pre-op workup and some of the things that are important. So you want patients that are refractively stable, right? That's not unique to this procedure. This is pretty much any refractive surgery you want to do. The last thing you want to do is treat a moving target. Typically, we're looking for on-label use, so pre-presbyopic patients between 21 and 45, stable with enough anterior chamber depth. Endothelial cell density, obviously there's age norms, and you want to look at, what's outside of those norms. So is something abnormally low for that person's age? Is the quality of those cells? Can you see guttae or something really, abnormal on examination? Nice wide open angles on gonioscopy. If they do have keratoconus, that needs to be stable. So often this is actually a really great application for EVO ICL, is those patients that have been cross-linked. Obviously, you're not going to go back and laser them, and they often have really strange refractive error. And these are some of kind of the happiest patients. But like every refractive procedure, the key is just having a nice healthy eye to kind of go into.
Kind of talked a lot about this already. The white to white, I think, is the one thing that if you work with EVO, that is directly going to be linked to your diameter. That's going to be linked to the size of the ICL, which will then impact your vault, which would impact your angles. So the white to white measurement is, how do you guys do it in your clinic? I mean, do you do white to white? Do you do
we use an
UBM?
orb scan, but I mean, there's multiple different things. And I think on one of our slides, you're going to see it can be measured with an orb scan, which is a form of topography that really isn't used by many clinics. So we're a little bit lucky that way. And I think it'll die at some point. It's not technology we plan to, redo over again. So we use a pentacam as well. We've used calipers. You can use, people use UBMs, which is not strictly white to white. You can use various forms of anterior segment OCT. So when we talk about sizing, so we talk about two things with the ICL. One is the power. So we mentioned, different forms of refraction and why that's important, why the manifest is so important. But also with the sizing, in Nick's case, he was talking about the size being too big, too small, and how that affects the vault. And I think that is something that, is very, very unique to ICLs. And the combination of the white to white and the anterior chamber depth is how we get to that size. And so that's kind of what we have here. So you have to assess your anterior chamber and looking at kind of the different settings there, again, making the distinction between internal and external, because if it's the external, you're going to, have the wrong measurement because you're going to add an extra 500 plus microns there. So those are always really important.
Yeah, the ciliary sulcus is what we're trying to measure.
Yeah.
I mean, and it's hard to measure it. It seems easy. Well, why don't you just use an OCT or an ultraviolet, some sort of device to measure that? But the other problem with the ciliary sulcus is it's not perfectly symmetrical, and there's some variability there, and it's not perfectly smooth. So you can put the lens in, and it can kind of rest on a crypt or a valley and kind of sit. There is irregularities to it. So that is the challenge.
Okay, right? Like with this kind of when we think about sulcus placement, like I said, I work in anterior segment, and you think about things like UGG syndrome, for example. You put something in the sulcus, this is a risk, right? And those are with kind of hard lenses. With this kind of soft material, you don't need to be kind of exact. As you mentioned, it's going to kind of settle in where it's going to settle in, and it'll find its groove and typically do really well with that. There's for white to white here, there's a bunch of different correction factors that can be used. There's actually a paper that came out very, very recently, like really hot off the press. But I think in most clinics, like for you guys, what do you use? And do you have a correction, like a fudge factor, I guess?
Yeah, we use the pentacam. So Micheletti was the one who had the paper, and he talked about different devices and kind of a fudge factor on which devices are more accurate than others. And they're all accurate if you use the same device. You kind of have to have a little bit of a comfort with the device. We use the pentacam, and we're comfortable with that, and we kind of know, how we need to adjust our size based on that. But if you use an orb scanner, if you use just manual calipers, I mean, that's an old school way, but that's how they did it with the FDA trials. Using the same method over and over again, you get a feel for how it works. It's like using the same, it's like my golf clubs. Like I use the same clubs every single time. You get a feel for, well, how far into the woods am I going to hit this one? You get the feel for your own equipment. And that's really, I think, the key with it. There's a fudge factor with it.
Well, it's also so forgiving that, like, really, we stress over it just because we all have, that type A personality that serves us well in work, but also like we know that it's going to be okay.
Yeah. Let's flip it over then. So we go through surgery. Our surgeon colleagues do a fantastic job. Lens goes in, everything goes well. What are we looking at?
We'll gloss over that part,
Yeah.
Minor detail. We'll get back to us, back to the OD, heavy lift. This is how we measure vault. And I think, when I train our community ODs, when we have them come in and often have them have an open door policy and come and have a look at a few of these, because vault, is very unique to the EVO ICL. So you look at kind of the distance there. You can see it in between the slit lamp beam. I don't know if we can even see it in there. So whether it's a normal vault, whether it's shallow, whether it's a high vault. So looking, where the placement is of the ICL, and you can just see this at the slit lamp. You don't need any fancy equipment. Sometimes when we're running training, we'll actually do measurements like on an ASOCT, but you really don't. And once you see a few of these, you really kind of get a feel for that. You look at the distance between the beam there. I don't know if
there's a scan right here. Take a look at that one. So that's
a great one too.
So, I mean, Anu, let me ask you this then. So, if you've got a patient who has a vault, so we do it down and dirty. You're comparing it to the thickness of the cornea. You assume your cornea is about 500 microns, right? 500 is kind of ideal. The lens is extremely forgiving, though, so you can go as low as off-label, like maybe borderline label. If you're down to 50, leaving it in there is fine. All the way up to as high as you want. If you have a high vault, what's the next thing that you're going to look at?
So you're looking at your higher vaults, you want to look at the angle.
Yep.
And that's really what you're treating. You're not treating like the vault is something we measure, we track, that kind of thing, but we're treating the vault. So if there's no issue there, if the IOP is okay, the angle's okay, you're not worried about anything.
Yeah,
We can
it's
watch
like
it, we can feel
glaucoma.
comfortable.
I
Yeah,
mean, glaucoma, you're not treating the pressure,
yeah,
you're treating what the pressure is doing, right?
that's right.
Your vault
Makes
is your
sense.
risk factor, but the angle is what you need to keep an eye on. So the vault is just how we track it. That's how we look at it, just like we measure pressure. But if I got a patient who's got a pressure of, 15, but for them that's way above target, that's still a problem.
That's
And
right.
so that's what you're treating. So let's talk a real quick. We got a couple minutes left here. We'll talk about the why, and I kind of hinted at that. Why are we improving vision? Let's talk about optics. We're going to go back to these ray diagrams. I know everybody loves the ray diagrams from their optics days back in optometry school. So if we have an incident ray, we've got this just simplified system: our contact lens, our cornea, our crystalline lens onto the retina. Well, there's a reason why high myopes like contact lenses better, right? It's retinal minification. So if we correct the vision in front of the corneal plane, that is going to shallow out our incident angle, and we're going to be left with a certain retinal image size. Well, if we can adjust that, right? If we can correct vision on the corneal plane, well, that's going to give us a much greater retinal image size. Ask anybody if you're a myope out there, you probably like when your contact's better, assuming they feel comfortable, because of the increased retinal image size. It's just crisper vision. So that theory, the reason that we myopes tend to like that better is because of the nodal point. The nodal point sits about 17.2 millimeters in front of the retina, right at the anterior crystalline plane. So if you can correct vision better or closer to that nodal point, you're going to improve vision. And so that's why our patients do actually get improvements in their vision. And they can actually, they come in, they're 2025 plus or so. If you've got a -8 individual, they leave their 2015. That's very, very realistic. So we talked a little bit about why LVC isn't always the best choice. There's several reasons. I mean, there's thin Ks, ocular surface disease. I mean, patients who come in with dry eye, contact lens intolerance, and then corneal irregularity. I knew you mentioned it. You can do ICL with keratoconus,
Yeah.
and you
I
couldn't
think
do
those
LASIK.
ones are great because they don't really have another option. But I mean,
Mhm.
let's think about those ones where they come into your office and they've just got those weird topographies. I think Dr. Blumenstein calls them like FLT, funny looking topographies, which I love, and I'm totally
Yeah.
stealing that. But they're just a little wonky. They just make you feel your spidey senses tingling a little bit. For those of you that use a pentacam, you've got your Balin Ambrosio scale, and it's not quite right. So it doesn't have to be this kind of like super bad, like a 400 micron cornea is, I can't think of kind of an obvious one, and same thing with the topography, but those just, not quite right. Why take the chance?
Yeah. Yeah. And it's dose dependent. So the
Yes.
more prescription you have, the
Yeah.
more ablation you need to do.
And the higher
ICL,
the
that
risk for
lens
myopia.
is, yeah, the higher risk.
Yeah.
ICL, it's the same size lens pretty much going in every single time.
Yeah.
So you don't really have to worry about that.
Well, you're not worrying about severing corneal nerves. Obviously, no one would say that that an ICL is, of course, like the treatment for dry eye. Of course not, right? But often these
Mhm.
patients are contact lens abusers and overwearers and what have you. We're all on screens too much, so you take that out of the equation. No matter what refractive procedure you do, you've taken the offending factor out. But by operating on the cornea, you're probably going to take an at-risk eye and kind of tip it over the edge a little bit. Whereas you go inside the eye, you're reducing that risk further, which is great.
Yeah, that's why I've got the question mark next to the word invasive here.
Yeah.
So it doesn't seem invasive, LASIK, because you're not cutting into an eyeball, but you are definitely permanently altering a cornea. So less invasive, or is it even more invasive?
Yeah, it's a
Arguable.
really tricky word that way, right? When you think of something as not being reversible, it really does seem kind of worse. But I mean, when you traditionally think of intraocular surgery, which of course, ICL is, it's one of those things. So I think you could easily make the argument either way, I think. And neither would be wrong, in my opinion.
Yeah. Last point here. Again, we already talked about this, but at some point, if you live long enough, these things are coming out. They come out. I mean, you can see the crystal clear picture right there. And I've heard from plenty of accounts that these lenses come out in the same condition that they go in. They are completely biocompatible. They don't sclerose down. They don't they come out very, very relatively easy. I've never removed one. I'm not a surgeon, but from what I understand, they come out very, very easily. And it doesn't impact cataract surgery down the road. So it doesn't affect your calculations. LASIK does. LASIK does. I know you've seen refractive surprises. I have too. Those are very unhappy patients because those patients have very high expectations. This does not affect them. We can account for this, and we have the full range of premium lens on the table for patients. You're future-proofing your eyes by doing a procedure like this instead of laser vision correction.
There's a lot to love for sure.
Yep. Well, that's pretty much all the time we have, everybody. I want to say thank you again. Thank you to our sponsors. And please be on the lookout for a survey. I'll send a survey out soon here so we can make sure we get COPE credit out to everybody. So Merry Christmas, Happy Holidays, Happy New Year. We'll see you guys later.
All the best. Thank you.